back, everyone. This is the second in a series of Contura patients. This one's going to be a little bit more difficult, and we will make the assumption that you've gone through the first case before looking at this one, because we won't be describing every bit of the reconstruction and all that stuff on this case, because there's some more interesting features to be talking about. Now, we've started here just the way we did the last time. The patient has been imported by Brachyvision, and automatically the external contour has been generated as part of the import with all the default parameters. And it gets it wrong in two ways, one of which is entirely cosmetic, and the other of which is rather subtle but extremely important. So let me go over those first, and I'll tell you about this little problem with Brachyvision. Varian knows about it, and they're working on it. Now, the first thing that you can see, if you look here, is that the couch has been automatically contoured as part of the volume. That typically happens because when they do an automatic import, they don't know where to set the box to limit that. That's really just a cosmetic problem. But if we zoom in on the area around the balloon, we'll see a much more significant problem. And you can see here that the skin contour over the top of the balloon should be right up here, but it's been depressed to this location, and that's a bug in the software. And if I scroll up and down a little bit, it gets better farther away from the balloon, and it appears to be affected by this low density region here. So what would happen as a result of this is that we're going to be generating a lot of structures that are affected by where the skin contour is, and so that can make a number of things wrong. Remember that we last time calculated an external volume here called the skin max. If I turn that on temporarily, you can see where that's supposed to be and where it would be if it followed the default skin contour. And you can see that it would be the high dose that we got for the skin would be at this location, which is about 2-3 millimeters below the skin surface in an area of very high gradient. And so you would get an artificially high skin dose there that isn't real. More importantly than that, however, is the PTB surface and the PTB for evaluation. Both of these are going to be generated with respect to the skin contour, and if they were generated with respect to this contour with 5 millimeter distance, they would be way down here, and they would be very wrong as well. So this is not just an issue of getting the skin maximum correct, it's also an issue of getting the structures correct themselves. So let's have a look at that and see what we can do to correct it. I'll go back to the body here, and let's zoom out a bit so we see the whole body. Now, if we were going to correct this, the way we would do it, the first thing we have to do is throw away the original structure, so we've got to clear it on all planes, like that. Then we will want to set a box. Since we're going to do it manually, we can set the posterior margin to exclude the table there. That's about all we need to exclude. And then we'll go to the search body. Now, you can see that by default you get this small dialog box. If you ask for the details, you see what all the defaults are. Now, by default, the search body will have the smoothing turned on at a level of about 3, and that is causing the problem, that artifact. So in order to get around that, what you need to do is open the search body dialog, ask for the details, turn the smoothing off, and then you want to save these settings as the default so that when it does it in the future, it will not do smoothing. It is possible after you do the body contouring, or after it automatically does it, to come back in post-processing and do that smoothing, and it'll actually improve the contour rather than making it worse. But let's look at what happens then if we create it the proper way without that involved. And there's another little bug here that the progress bar doesn't finish. And let's zoom in and see where it's fixed at. And of course, it's now correct, although it's a little ragged, as you can see. But if we just go into here and ask it to do the smoothing now. It's getting ready for that. And apply that. Watch here and see what happens. You see that it's done the smoothing properly now. And so we have our skin contour where it is supposed to be. So that's one issue that you will have to be very aware of. This doesn't happen on every case, and it happens in certain other areas as well. It happens where the catheter is on the outside of the body. If you look way down here, it'll get it wrong in this area too, but this is so far generally from the area that we're interested in that that's not really important. There's another issue here, and you can see that it looks like there's air in the balloon here, but it also looks like there's air outside the balloon. And you remember how I mentioned on the other case that if you use the ellipse tool, it's nice to take a diagonal so that you're not starting in here and guessing where that should be. Imaging like this, which of this is inside the balloon and which is outside the balloon. But in this particular case, if we set the window and level settings very wide, we can actually see it. And you can see right here, here's the balloon surface. And so this part is inside the balloon and would be contoured as part of the applicator. This part is outside of the balloon and would be contoured separately as air. And you can see its volume isn't very large. An experienced user will probably not even bother contouring it. But you can do that and do it separate. So let me set our view back to our normal parameter here, which is about 1,000. Okay, and we can go on from there. Now, as we pointed out in the first session, the way that these body structures are defined is a clinical decision and needs to be made in conjunction with the radiation oncologist. And what we have done in this particular case is maybe not what every oncologist will want to see, so you have to ask that question. So what we've done here is we've defined the ribs as being only the bony ribs. It actually includes a little bit of the sternum here. But if I scroll up and down, you can see, well, we're probably going to capture the high dose to bony rib here. And up above, do we have any? Yeah, we have a little bit here as well. But through the central part of the balloon, there's a large area of chest wall here that we are not accounting for. We don't evaluate that in this particular plan, and we don't optimize to reduce the dose to this structure. And there are some radiation oncologists who would want to reduce explicitly the dose to this chest wall, and if that's the case, you want to be contouring that as a separate region of interest. We would put in the chest wall just the way we did in the original case, like this, as a blocking structure only, not for evaluation. So just keep that in mind, that that's a clinical decision that needs to be kept in mind, and the final optimization we get from this case will be a little bit different as a result of that. Now let me just show you what some of the other structures look like in this case. This is our PTV for evaluation. You see that it breaks quite significantly if we scroll up and down. Actually, the fact that we have little islands here and so forth really doesn't bother the planning system at all. It works quite well. But that's a normal consequence of a very small skin distance and a small rib distance at the same time. If you look at the PTV surface instead, you see that we get this nice convex surface that is equivalent to the outer wall of that PTV for evaluation. And that we use, as we stated before, only for optimization, not for evaluation. And in this case, the PTV volume for evaluating the V150 is quite large here. And here you can see it's different. Here's the PTV 150. It's different in this region than the PTV for evaluation is, which is here. So I'll go back and forth between those. And you can see that this V150 volume accounts for the dose to this breast tissue in this thin region here, which makes a difference. So in this case, we're going to have to put our V150 and V200 parameters on this volume rather than on the PTV itself. All set up to do the reconstruction. In this case, I've already done the reconstruction since I showed you how to do that on the first case, but I wanted to show you a few other features of this particular case. In this case, channel 1, you can see here, has that lightweight nitinol marker. You can pick it out here. And number 2 is this one here, which has a marker in it. And you see in this particular case, in the transverse view, we're seeing it from the opposite direction. So they're increasing counterclockwise. Keep that in mind. You can't always tell which way that's happening, so that's why it's useful to have markers in both of those. You can see in this case the marker under channel 1 is very well shown. In some cases, it isn't seen very well at all, and we have had some reports recently that some people have trouble picking it out at all sometimes, so you have to be aware of that. It might be useful to put in markers in more than just channel 2, maybe channel 2 and 3 with some sort of a protocol of your own so that you can distinguish those two. But we've already reconstructed all of this, so that's not too much of an issue. Now I would like to talk a little bit before we go on about the issue of why we do a 5 millimeter distance from the skin here. The original B39 protocol specified a 5 millimeter distance from the skin for the PTV eval and for any other structures for all the modalities. And the 5 millimeters originally was there because of the uncertainty of calculating the dose in the first few millimeters for external beam treatments. It's quite inaccurate, especially if you're trying to do IMRT, which is not allowed on B39. But because of that, in order to make all of the arms comparable when they were evaluated centrally, they placed that as a standard recommendation that the PTV would be 5 millimeters from the skin. Now, in some cases, there is tissue in that region that is of interest to be treated, and that depends on the philosophy of the individual physician. It also depends on the particulars of an individual patient, whether or not they might have had a close margin in a superficial direction. So what I recommend is that you always create this PTV surface at 5 millimeters from the skin, but that you create the PTV eval to be whatever the physician wants to actually treat. So it's possible that these two don't have the same outer surface. Under those circumstances, and you will see even now, when we do the optimization on this region up here is mostly going to get 100% anyhow, because we're trying to limit the dose to the skin to 100%, and so all of this region will get 100% anyhow, whether or not we actually evaluate it in the PTV eval. So that's not really the issue. The issue is how the physician wants to define the PTV eval for evaluation purposes. So just to keep that in mind, that there are clinical issues here aside from just the treatment planning in particular. In addition to that, in this particular case, you can see, unlike the other case, we have truncated the PTV for evaluation in this region. And so we won't be able to calculate the V150 and the V200 accurately in this region if we evaluate them on the PTV eval. If we look at the V150 volume instead, you can see that I've included all of this, and I've been fairly generous out here as well. Remember also that we don't include the chest wall in that, because the purpose for the V150 and the V200 is to avoid fat necrosis, which really is the only tissue that's implicated in that is the breast tissue itself. So just another item to keep in mind. One more note about this V150 volume. If we're going to put markers on the DVH as part of the optimization that are absolute values of volume, we'll have to divide by the volume of the V150 rather than dividing by the volume of the PTV eval. So if we look at its volume here, it's 155 cc's. So a 30 cc volume will be about 19% of that, and a 10 cc volume will be about 6.5% of that volume. I'm going to turn that off so that we don't have to look at it while this is the volume we really want to evaluate with isodosis. So we'll go directly into our volume optimization here. Move that up a bit. And we will start just about the same as we did before. We start with a PTV surface on the surface, and we'll put objectives on that. And we'll want the lower to be 90% and 95% volume, 95% dose, excuse me. And the upper one we can leave about where for the PTV eval. we just actually need a lower one now. So we'll just add one, change it to lower by typing in lower. And we want 95% here to 95% of the dose. And we'll set that at 100% priority. That's fine. Now for the V150 and V200, we're going to put them on a different volume now. So we'll just add them one by one. This is on the V150, and we're also doing it on volume, not surface. So we'll add one here. And so for our V150, we're going to set 19%. And the dose here is going to be 150%, which is 510. We'll add one more, which is an upper by default. And this will be 6.5%. And the dose will be 680, which is 200% of our prescription. Because they probably won't be used much for the optimization itself. We'll put the skin max in again, and we'll have an upper there. And we can leave this at about 5%. And we'll have the dose be actually the treatment dose, because that's where we'd like to hold that. And the other thing I wanted to do with that surface, I wanted to move this volume up to about 30%. Sorry. And we'll put in the ribs as well. And very similar to the skin. Here we want 125%. And that will be 425, just like last time. Set the priority way down because it's mostly for evaluation. Need to do that for the skin max too. Okay, and then we're going to rescale over here so that we can see this as well as possible, like that. And as before, we want to show all objectives, show all the penalty function contributions, show what the error function is in this graph as it goes down, and the dwell times. So we're ready to start again. Now, I don't expect this one to work out perfectly the first time. We're going to have to work at it a bit. So we'll just let this cook for a little bit, and we'll have a look at what's happening. We have the skin and the rib dose here. We'd like to hold them near this region. I think that I made one of those wrong. Let's check. The rib dose is 425, and I don't see it here. Unless I set it way on to put that 5%. There we go. And you can see that the rib dose is easily met here. The skin dose one, which is this brown line, is not being met exactly, but it's up here somewhere, more like 100%, 120%, something like that. You can also see that if you look at our PTV for valve, that's this one here, we want this line to go just through this point, and we've gotten a little bit more than we need, just like we did the last time. So we can probably take this surface weight and reduce the weight of it a bit, because it's 18% of our objective function, and everything else is pretty close to zero. So let's take this PTV surface one, and let's reduce this. And when I make these changes, I usually go for big changes first and then small changes later on as we converge on what's a more useful treatment goal. You can see perhaps that we have perhaps gone just a little bit too far here. Remember that this PTV DVH is not a real DVH. It's only on the points that we've generated. So it's there, but it's not very accurate. And the fact that we're really close here means that we probably need to move back in the other direction a little bit, that we haven't quite got coverage there. You can also tell, perhaps, that these points are being evaluated on this line, not on this line this time. Because remember that we didn't put them as percentages of the eval this time, but as percentages of the V150 evaluation. And unfortunately, the colors of these are very similar, so that could be a little bit confusing. But you can see that they're getting an error of 0%, meaning that they're associated with this line here that's below them rather than this line here. But it looks like those are going to be okay. Looks like this is perhaps okay, but we probably don't have quite enough coverage, and we have a little bit of a problem with the skin dose. So let's stop this, and we can look just a little bit at the dwell positions. Now, if you look in this first box here, this is channel number 1, and that one is directed directly toward the skin in this particular case, and there are no dwell times in there at all. That's good. This is the one, number 2, that's directed toward the head, and that's where actually the majority of the dwell times in this plan are. That's also good. This is the one toward the chest wall, and those are fairly small too. The one toward the feet, there are almost nothing here except for the one that is most posteriorly, and the one in the center, 0, nothing at all. So let's see what effect that has. Right there yet, I imagine. Now, we will do this just the same way we did before. We will turn on the dose volume histogram view. First time we do that, it'll automatically do the 3D dose calculation, I believe. So we have to select which structures we want to see. There's a PTV, the ribs, PTV eval, skin max. We have to see the V150 this time, and that's it. And of course, they've created this normal tissue structure in there. I'm going to turn the visualization of that off because we don't use that, and see what we have. Now, in this particular case, we get a warning in the DVH because the default calculation matrix won't cover our skin max. Let me show you the skin max. Here's skin max, and generally what they will do is they'll create a default box around the body contour. So we won't be calculating all of that volume effectively. So we're going to have to fix that before we go any further. And I'm going to go back and do that offline so that you don't have to sit here and wait for it to happen. I have reset to standard views here so that you can see that. And here's what the problem is, that it's the default 3D dose matrix covers the entire image area, not the area of interest to us. So what we'll do to fix that is to move this up so that all of this structure is covered. If we move the others in a bit so that they just cover the regions of interest to us, we'll get a very much higher resolution in our dose calculation. So I'm going to do that and reset this back to the views that we had, which the views themselves are more useful. Okay, we have that fixed now. So we need to look at our DVH in some detail and see what we have going on. I've set this relative dose and relative volume. That's what we need to do to show our coverage. And so we're going to look at something like V95 here. So I'll set this as close as I can get it to 95. And we have very close to 95% there. So I would call that a good day. We're okay there. Now we'll switch over to absolute volume for the other parameters. Now you can see in this particular case, this dotted line is the V150, and in the case of the 150 and 200% volumes here, it's identical to what we have for PTV eval. So we could have evaluated this on the PTV eval just as well. It would not have made any difference. And if we look at what the doses are, what the volumes are at those dose levels, let's see if I can get exactly 150 here. That's pretty close. We've got about 22 cc's for V150. That's perfectly great. And if we look at the V200, we've got about 6 cc's absolute volume. That's just fine as well. So so far, this is looking like a pretty good plan. Let's look at the doses for the skin and the ribs. Now we have a problem in here where they overlap. So in order to be able to select one or the other, I'll turn them on only one at a time. So I'll do the skin first, and we're looking again for 0.1 cc volume over there on the left. So I'll just keep moving this to the right till we get that down to just about 0.1. Well, it's in there somewhere. Okay, At about 0.1 cc, this is the maximum skin dose. It's about 103%. For a challenging case like this, that's really a good result. The Contura registry has requested that you try to keep the maximum dose to the skin below 125%. My personal bias is that that's not ambitious enough, that with good planning tools like this and with a good applicator like the Contura, you should be able to get close to 100% in almost all of your cases. So you should strive for that if all the other parameters can be met. And you saw that our V150 looked good here. Our coverage was pretty good. Let's look at the rib dose. Now the rib dose is going to be perhaps artificially low here because of the fact that we're only looking at the bony ribs and in this far apart in the region where the implant is. Let me turn the skin max off so I can see, so I can grab this one adequately, and I'm almost there. Okay, so the rib dose in this case, here we're only showing 98%. So that's an excellent value, but remember that it's a little bit artificially low. Here's where that percentage is. Whenever we pick out a dose on the DBH here, that isodose will be added to the list here. So it's added here in blue, and you can see where it is. It's right here where it impinges on this rib. Now if there was another actual bony rib in this region, or if there is a rib that is improperly calcified and not picked out, which could be here, it's possible that that dose that we're calculating is artificially low. And we have optimized to balance the skin dose and the rib dose here. So you have to ask that question very carefully with the physician about what the balances are for those. But that's what we have for this case, and it looks pretty good a priori, but there is still that caveat. Now let's look at what Okay, and let's look at in a little bit more detail about the V150. And you can see perhaps this yellow line is the 150% isodose, and the difference between what we calculate in the V150 volume, which is all this in here as well, and the actual PTV is only important if the 150% isodose line actually goes outside the PTV. Now let me go full screen with that one so you can see it a little bit better. And you can see this yellow line is not going outside the PTV for evaluation. If we put on the PTV surface as well, you can see that's where that is. So because we have a properly optimized plan here, it doesn't make any difference. But we have that for comfort to know that if it did make a difference, we'd have covered that in this particular case. Now there's another issue here to be concerned about. Okay, the other issue to look at is what does this implant really look like in terms of its optimization and how these are actually loaded. And you can see that this catheter that's toward the skin doesn't look like it has any loading at all. All the rest of them have something. But you don't know, these views will only tell you whether they're activated or not activated. They won't tell you what the actual times are. For that, we can look at the dwell control window. Pop that down here, and I can stretch it a bit so that we can get as many as possible. Now here you can see that I've given these actual names, and I recommend that if you have oriented these in particular directions, you can give them meaningful names so that when you do the printout, you have a little bit more understanding and it's more obvious about what you've done here. Okay, the channel toward the skin here, all the dwell times are 0, which is mostly what we want because we're trying, the big challenge for this case is to reduce the skin dose. Now, the next one here, number 2, is actually toward the head. So we've marked that as head, and this is where the bulk of our dwell times are, as you would expect. If I move this over here, that's this catheter right here. The reason that this gets more dwell time than the one toward the feet, if you look at the one toward the feet here, it's got some dwell time at either end, but mostly not, and the total here is quite small. Now the reason that happens is that we're trying to optimize the volumes. Remember that all this optimization is based on the DVH. So you can perhaps see in this view that the volume of PTV toward the head is much larger than the volume of PTV toward the feet. So there's more optimization points in here, and it gives this more weight than it gives this. So we're sacrificing a little bit in here in order to get more up here, which makes good sense in a volumetric sense. So that's why the optimization looks this way. And if we look at catheter number 5 in the center here, this implant has required a lot of modulation. And whenever you need a lot of modulation, this is the consequence, that the central channel gets almost no dwell time, everything out. And this is not a case where we want to even everything out. So when you're doing the volume optimization, there's no need to eliminate that central channel. I would just leave it in there, let the volume optimization do its work, and modify those parameters as you need to, as we showed here, and this will be the general result. If you need less modulation, you will get some dwell times in here. If you were in a position where you had to do all this by hand, this would be one of those typical cases that we wouldn't even reconstruct that one, because we know that we can get more modulation if we push the catheters out a bit. But you get it for free in the volume optimization in this case. Okay, so as you can see, we have achieved a very good plan here without doing any graphical optimization, which in general I don't support. You can try that if you like, and it's probably not a bad exercise once in a while to try, to create a plan in this way, get the best plan you can using volume optimization, save the plan and copy it, and then go to your graphical optimization, and see if you can make some parameters better that make you particularly nervous, but then evaluate on all the parameters. Look at the coverage, look at the V150 and V200, and look at the skin and rib dose. My bias is that if you do this correctly, and if you learn to use the volume optimization effectively, every time you do that, you will pay a price somewhere. And it may be a price worth paying, but most of the time it won't be. The other issue is that if you need to do more modulation to get the skin dose down, or to get the rib dose or the chest wall dose down, you can add those as additional objectives in the optimization, and they will change the modulation. But my experience is that using that PTV surface and adjusting the parameter on that gives you quite a good deal of optimization, as long as you don't do that as a sole optimization. You want to have the objectives in there for the PTV gal as well, and for the skin sometimes. So just make sure that you have all of those things in there at the same time. That optimization method is extremely easy to do if you have your V150 and V200 and skin and rib doses showing in that histogram. That allows you to tune all those parameters, and you see whether or not you're violating the dose somewhere else. So it's a very effective way to do that. Now, there is another issue, and that is that if you are nervous about the dose to the chest wall here, you can include that as part of the optimization. What will happen almost universally, though, is that the dose to the skin will get higher. And that's a question for the physician to address. We know, though, that the skin is exquisitely sensitive to dose. We don't know so much about the chest wall. There have been sporadic reports of rib fracture and chest wall pain after these. Generally, it's a late toxicity, but it's not well correlated with doses calculated to those structures. So we don't know for sure. That's why there are recommendations for dose to the chest wall and ribs to keep them below 140%, something like that. But we don't really have as much information about that as we do for the skin. But you can see that the optimization that we've done in this particular case is a reasonable optimization. An individual physician, and especially an individual physician with knowledge of the particular sensitivities of the patient in front of him, may make different choices, and that's entirely legitimate. I would also say that every time I run this plan, I get slightly different values for all these parameters, and that's because the optimization is exquisitely sensitive to how these individual structures are defined. And the general weights of the structures will make the optimization a little bit different. So there are differences that I see in these optimizations, and those are reflected in the DVH values you see a little bit, but not very much, because we'll change the parameters to kind of push them back toward what we expect to get. But generally we get something that we very much like what we see here, where the one toward the skin is little and the others carry the weight. So I hope you've enjoyed this case. Try doing this on your own, and it will be, I'm sure, very instructive.